Hi, I'm Jocelyn, and this is a rebuttal of the against position for the debate that breastfeeding should be the expected feeding method for all newborns, and formula access should be restricted to those with medical conditions. Thank you to my opponent for her thoughtful presentation. I will be discussing the weaknesses and flaws within the argument for the against position. My opponent's arguments center around four ideas. First of all, that patient choice is a primary concern, that restricted access to formula is unethical, that it could increase stigma, and that there's a lack of breastfeeding support. Therefore, breastfeeding should not be the expected feeding method for all newborns, and formula access should not be restricted. I want to start with some concessions and debunking. First of all, I listed only the medical indications for breast milk substitutes that exist at birth, so I thank my opponent for listing those that arise after birth, such as weight loss. Next, we agree that we need more breastfeeding support. I totally agree, and we're going to discuss this further. My opponent made a claim regarding health outcomes for breastfed and non-breastfed infants. I'm not going to spend time here because it's simply a false claim and in opposition to every major healthcare authority on earth. Lastly, my opponent appeared to operate under the assumption that breast is best. I would argue that this is false. Breastfeeding is the biological norm. It is not best, but anything other than breastfeeding is a deviation from the physiologic baseline. Let's talk about patient choice. Clinicians must trust that a woman will choose to do what is best, even if the woman's definition of best is different than that of the healthcare provider. This is taken from my opponent's opening statements. Imagine if we applied this statement to other public health initiatives like smoking, alcohol and pregnancy, STI testing, or childhood immunizations. We can support women who choose not to breastfeed using a harm reduction model and support while acknowledging and managing accurate risks through formula restricted access. My opponent claims that most women aren't breastfeeding in the months that follow birth, and it follows that they probably didn't actually want to. But in fact, over 90% of women come to the hospital planning to breastfeed, and whether they receive a supplement in hospital of formula is a key predictor for formula use in the future. My opponent also claimed that hospitals are already using best practices when it comes to formula. The Baby Friendly Initiative is a set of best practices from the World Health Organization regarding breastfeeding and breast milk substitutes. But the fact is that very few hospitals are actually following these practices, and a significant portion of babies are receiving non-medical supplementation in hospital. The math does not add up. 90% of women want to breastfeed, 28% of babies are receiving non-medical supplementation in a short hospital stay. Is this what supporting women's choices look like? Policies that increase breastfeeding are supporting women. The next claim is that formula is not a medication. This is true. Formula isn't classified as a medication, but as I mentioned in my opening remarks, it does meet the criteria. Patients have choices about their medications, but those choices are limited by solid evidence-based criteria for prescribing. The current situation is not an argument for keeping things this way. Looking at ethics, my opponent claims we need to represent the client's point of view and not our own. But the baby is also our client, and in almost all cases, breastfeeding is in the best interests of the baby. And in most cases, breastfeeding is in the client's interests as well, and it is her intention. Next, my opponent claimed that restricting formula access will lead to infant deaths. This appealed to emotion accompanied by anecdotal stories is not accurate. Breastfeeding is one of the most effective ways to ensure child health and survival. When it comes to stigma, the opposite argument is that restricting formula access will further stigmatize women who don't breastfeed. But in fact, restricted access is treating formula as it should be, a medical intervention, a deviation from what is normal, and an indication that a family needs healthcare support with infant feeding. No one is shaming women, but barriers to choosing not to breastfeed need to be erected. Look at this beautiful photo of 3 babies eating. All 3 ways are good. Only one is the biological norm. Does the fact that women cannot choose to tube feed their baby shame them? When it comes to support, absolutely, there is inadequate breastfeeding support available. I totally agree. Physician and midwife education needs to be changed to include mandatory minimum breastfeeding education, and international board certified lactation consultants need to be integrated into primary care. But restricting formula is a tool to increase availability and funding of breastfeeding support. A lack of what is right is not a reason to continue doing what is wrong. To sum up my rebuttal, yes, we need formula to exist. It's an essential tool. Yes, we need more breastfeeding support. Absolutely. Yes, formula-fed babies need more support and education. But what's the argument against restricted access? Restricted access for formula could help us in all of these situations. Thank you.